Right. Okay. Today we are going to talk about appendicitis and diverticulitis. So, how many patients of appendicitis have you seen during your appointment? Because you get appendicitis every day to the casualty ward, emergency ward. How many patients have you seen? All of you have seen at least one? Hello?
Yes.
Have all of you seen at least one patient with appendicitis? Don't tell me I have not seen, because it's so common. If you have not seen, that means you haven't been to the wards. Have you seen at least one patient?
Yes,
What was
sir.
the presentation?
Yes, sir.
Yeah, what sort of presentation? How did the patient present? Tell me how the patient present to your ward. Talk. Come on. We'll have a small chat until we start, so that the others can join. They are still being joined, so let's have a chat. What's the presentation? How did they present? How did the patient present? What's the age? Was it a child or an adult or elderly? Yeah. How did the patient present with appendicitis? Anyone? Hello?
Child.
A child, right? Okay. What's the age? A child. You have seen a child presenting with appendicitis. What sort of age? Roughly. I don't want the exact age. Just say how many years, roughly about. Very poor participation, very poor talking.
13 to 15 years.
Okay, around 13-year-old. Boy or girl? Was the patient boy or a girl?
Boy.
Boy, right? Okay. What's the presentation? 13-year-old boy presented with appendicitis. So what's the presenting complaint? There you are, big gap between the question and the answer. I have to ask the same question about 10 times to get a word out of your mouth, which is not good.
Acute right-sided iliac pain.
Acute onset?
Right iliac pain.
Very good. Well done. Acute onset right iliac fossa pain. Right. Excellent. So that's the commonest typical presentation. Right. Okay. Well done. So are there any other causes for this pain? Is it the only cause? Appendicitis, is it the only cause for right side iliac pain? Right iliac fossa pain? If somebody comes with right iliac fossa pain, what are your differential diagnoses? Do you think it's only one differential diagnosis, or there are so many? Choose one of the two. Are there so many differential diagnoses? Only one differential diagnosis, and that is appendicitis. Which one do you think? First one or the second one? Where are you? I can't hear anyone.
Diagnosis.
There are so many differential diagnoses. Very good. So therefore, it is very important when a patient suspected to have appendicitis that you have to exclude all the other differential diagnoses and come to the diagnosis of appendicitis. Otherwise, you will make a mess out of it. So therefore, remember, there are so many other causes that can give rise to the pain in the right side of the abdomen. Right? Can you name a few? Urinary colic, mesenteric adenitis. What else? Non-specific abdominal pain. What else?
Right-sided.
colic.
Urinary colic, I said, right, good.
Right-sided
Adenitis,
pyelonephritis.
yes. I couldn't hear you.
Right-sided pyelonephritis.
Yes, pyelonephritis. There are so many. And in a female, there can be tubo-ovarian problems, so many causes. So therefore, it is very important, especially when a child comes with right-sided abdominal pain, because the parents are very anxious. Right? They have heard only about appendicitis. They think it's appendicitis. Every time when there's some pain in the right side abdomen, everybody thinks it's appendicitis. So the parents are very, very anxious to see what's happening. So you have to consider all the differential diagnosis. At the same time, you have to explain to the parents that there are so many causes of appendicitis, and what we are trying to do is we are trying to exclude everything else and make a diagnosis of appendicitis properly. Otherwise, they are very anxious. They tell you, oh, what is this doctor is doing? They're not doing anything. They are just keeping the drip and examining again and again. So you must explain to them. You have to communicate properly with the parents and tell them that right side abdominal pain can be due to many causes, not only appendicitis, because it's very fair by the parents' point of view, but they have heard about only appendicitis. So every time when there's right side abdominal pain, they think it's appendicitis. So they will blame the doctor. Oh, they are not doing anything, only giving saline. That sort of story. You must tell them, right? So it's very important to relieve their anxiety, especially when a child is not well and admitted. They want you to do operation immediately. That doesn't do, right? You know, you must make sure that it is appendicitis, not anything else, and you have to make a diagnosis properly, right? Okay, very good. You have seen a lot, I think. Yes. So what is appendicitis? Appendicitis is a definition of its definition is acute inflammation and infection of the vermiform appendix. Now you should know where this appendix is, right? It's in the is at the level of the end of the small bowel and beginning of the large bowel. Is attached to the cecum, and there are many positions of the appendix which you will remember in your anatomy. There are so many positions of the appendix that you will have to appreciate, because at the time of operation, otherwise you will not be able to find the appendix at the time of operation. So there are so many positions: a normal position, right? Retrocecal, pre-ileal, post-ileal, pelvic. So many positions which can be there. So you must remember these things. Otherwise, when you start operating, you might not be able to find it properly if you don't remember that there are many different positions of the appendix, right? So, what's the etiology of appendicitis? The etiology is it is initiated by luminal obstruction by a fecolith. There's lymphoid hyperplasia or edema. Rarer causes of obstruction include helminths, your worms, you have learned in your parasitology, and sometimes in elderly people, you have to remember that this can be due to a cecal carcinoma as well. So a cecal carcinoma obstructing the appendix orifice in the cecum can give rise to appendicitis. What's the epidemiology? So it is the appendicectomy is the most commonly performed operation in the world, worldwide. Most commonly performed operation worldwide is appendicectomy. It can happen in any age. Peak incidence in the second and third decades. One of the most common emergency general surgical admissions worldwide, right? So if you consider worldwide operations, emergency operations, it's the most commonly performed operation. And it's interesting to see how many appendicectomies that we do in Karapiti Hospital. When you start your clinical appointments, you must inquire how many do your ward does in 1 week, and you can multiply and see roughly how many cases you do per year. Interesting to know, right? So about 7% lifetime risk in the UK population, right? So what is the commonest presentation of appendicitis? So classical presentation. So somebody told us roughly around 50% of patients will present with the typical presentation of abdominal pain. So usually, initially, this pain is diffuse. It's periumbilical and colicky. Now, these patients will initially go to your family doctor or a general practitioner and will say pain in the central part of the abdomen or sometimes in the epigastrium. So usually what is the treatment you are being offered? You will be given treatment for gastritis. But after about few days, you see the pain is not relieved and the pain moves and pain shifts to the right side of the abdomen. It's not pain radiating, it is shifting. Pain in the central part of the abdomen, periumbilical or epigastrium, and it has now moved or it has shifted. Now that pain is in the right iliac fossa. The initial pain where it was in the epigastrium or the periumbilical region, it's not there anymore, but the pain now has shifted. So it is a shifting pain after a few days. So then patient invariably will have to come to an emergency unit. So if you are the general practitioner or your family doctor, it is very important to tell the patient this may be gastritis or This may be the initial part of appendicitis. So if you don't explain to them, you will lose their respect and their confidence about you. So therefore important to tell them, right? If you are not getting better with your treatment, come back to me, or you can go to the emergency services of a closest big hospital. It's always important to advise them. The pain becomes sharp and localized to RIF. Now you should be able to tell me why this pain initially starts at the central part of the abdomen or epigastrium, and then after some time, after maybe some people 1 or 2 days, sometimes some people it happens quicker than that, the pain shifts to the right iliac fossa. And with your knowledge in anatomy and physiology, you should be able to tell me why this pain starts in the somewhere else and moves and it shifts to another area. So somatic pain as parietal peritoneum is involved. Initially, it is the dermatome, it is the pain itself in the organ, which has a dermatomal distribution of T10. That is why you get pain in the central part of the abdomen. As time goes by, the parietal peritoneum is involved with the inflammation. Remember, if the patient is having a good appetite and wants to eat, very unlikely that the RIF pain is due to appendicitis. And nausea will be common, and sometimes some people will vomit as well. Right, so that is the classical presentation, the typical presentation, the patient you have seen, right? That is what we see most of the time. Central pain, shifted to the RIF, but again, sometimes the patient won't remember this central pain. They will remember only the RIF pain. So they will come and say pain in the right iliac fossa. That's the classical presentation. So what are the other presentations? Alternative presentations. Pain in the right flank. When can you get pain in the right flank? Can you think about it? I have mentioned to you about the positions of the appendix. Yes, the position. If the appendix is retrocecal position, appendix lying behind the cecum, so you won't get typical RIF pain, you get pain in the right lumbar region, fairly higher up, maybe in the subcostal region, sometimes you get pain. So pain in the right flank, when the cecum, the appendix is retrocecal. Sometimes right upper quadrant pain, that means right upper quadrant, right hypochondrial pain, immediately below the right costal margin. When can you get that pain? If the appendix is very long, if the tip of the appendix is lying behind the ascending colon and is very close to the rib cage, right hypochondrial pain. So you might mistake this to other differential diagnosis which we have mentioned earlier, biliary colic or cholecystitis. So right hypochondrial pain can be there. Then lower abdominal pain. If the appendix is lying in the pelvis, you get pain lower down in the RIF. If the appendix is in pelvic position, and it may be associated with urinary frequency. Sometimes the tip of the appendix can irritate the bladder. If the tip of the appendix, usually the appendix tips get inflamed initially. So if it irritates the bladder, you get dysuria and frequency. If the appendix is irritating, the tip of the appendix is irritating the sigmoid colon, you can get, what can you get? You can get loose stools, right? Here you are, urinary frequency or loose stools due to bladder or bowel irritation by the inflamed appendix. That is the usual classical as well as atypical presentation. So what are you going to do if you get a patient like that? So in the emergency department, you are working as a house officer in the emergency unit. A patient will come say an 18-year-old male boy coming in with right iliac fossa pain for 2 days, right? So how are you going to sort out this man? So you take the history, you have, as I mentioned, the way history taking, and you will move on to examination. When you examine, some of them will have fever, mild pyrexia. It's not a big, it's not a very characteristic feature of appendicitis. Fever may not be there most of the time. If it is there, it will be very mild. The patient is highly febrile, high temperature spiking, that is very unlikely about of appendicitis. It may be perforated appendix abscess, but in straightforward appendicitis, you get very mild pyrexia, facial flush, and tachycardia. Then you have to, after the general examination, you will have to move to the examination of the abdomen, right? So how are you going to examine the abdomen? Abdominal tenderness, often maximal at McBurney's point. Now, you should know where the McBurney's point is. This is learned in anatomy. McBurney's point. You get maximal tenderness at the McBurney's point. Okay. So I have included that 2/3 along the line from umbilicus to the anterior superior iliac spine. You feel it and you press and you will see there's maximal tenderness. And there is rebound tenderness. The rebound tenderness. When you press, there is pain. And when you release, there's more pain. When you elicit these clinical physical signs, you must tell the patient before you do that, I'm going to do this, and do you feel more pain? You can't just examine patients like animals. So you have to tell them, I'm going to press on this area of the abdomen. Tell me if it hurts, right? And if the patient says, yes, I'm feeling pain, then you must say, I'm going to release my hand. Tell me whether you are feeling more pain, right? So I have seen people examining patients like animals. That cannot do. You must treat these patients as humans, right? Otherwise, I'm not going to pass you. So you must tell whatever you are going to do with the patient, you have to tell beforehand, right? And there is tenderness and there is rebound tenderness. What is rousing sign? Does anyone know what rousing sign is? You can wake up from your sleep and tell me. Hello, what is rousing sign? Can you hear me? Hello, people.
Yes, sir, we can hear.
Yeah. What is rousing sign?
When we palpate the left iliac fossa, patient experience the pain on right side.
Very good. Yeah. You feel the left iliac fossa and ask the patient whether there is pain on the right side. You get pain on the right side, and that's called rousing sign. Right. Okay. So a little bit about pathology or pathogenesis, which you have learned in your third year. Have you all done this thing in pathology? Pathology, pathogenesis of appendicitis was done in pathology or not?
Yes, sir.
You are done, right? Okay. Just a summary here. Luminal obstruction results in proliferation of small bowel, of bowel flora and inflammation that extends transmurally. Swelling results in obstruction and thrombosis of end arteries, and the appendix becomes gangrenous and necrotic. This is the pathogenesis and pathology in a nutshell. The inflammation may become localized by omentum. The omentum come and cover this inflammation, or bowel loops can come and cover this organ, which is now getting inflamed, to form an appendix mass. So appendicitis sometimes will progress to formation of a mass. How does that happen? With the inflammation, the omentum or bowel loops can come and cover it, surround it. So when you examine the abdomen in this patient, you will feel a mass. So the management is quite different, entirely different. If you feel a mass, you don't operate. That is very important for a house officers to get the feeling of straightforward appendicitis or appendix mass. Otherwise, you will fix this patient for surgery. At the time of operation, you will see there's a big mass formation and operation cannot be done, and you have done an given unnecessary anesthesia, an unnecessary incision in that patient's abdomen. So as house officer, you must differentiate, should be able to differentiate mass and non-mass, right? So that for you to do that, you have to examine patients in the ward. When you go to do clinical appointments, there are no point gathering around and chatting. You must see patients, right? So that we will make sure this time when you come to our appointment, you are seeing patients. So it's very important, otherwise you might fix unnecessary operation for a patient. So the appendix will be covered with omentum of bowel loops, and when it is covered, and sometimes the appendix can rupture, then what can happen there? The mass becomes an abscess. Mass becomes an abscess. Then when there is abscess, there's pus collection. Your patient will develop fever. I told you in the beginning. So there will be high temperature spikes up and down. Patient may be very unwell. So that is the time when the appendix has perforated and the abscess has formed, not straightforward appendicitis. So appendix mass or abscess or perforation may occur with peritonitis if not treated. So this is the normal pathogenesis. What happens in appendicitis if you don't do any treatment? Right. So what are the investigations that you are going to do? So is appendicitis a clinical diagnosis, or does it need a lot of investigations? Which one will you choose? One or two? One, right. So most of the time, about 90% of the time, appendicitis, especially in a male, is a clinical diagnosis. You can make a diagnosis without any investigation, with your careful, correct history taking and proper examination. You should be able to make a diagnosis. Only rarely, only you will need further investigations to support your diagnosis. So you will do, if you want to do investigations, you will do a full blood count, and the high white cell count should be there. And if you do CRP will be high. And you will do blood urea and electrolytes and RBS just for to assess the fitness for anesthesia. Make sure that they are okay. And sometimes if you are in a difficulty in the diagnosis, you might do urine for microscopic culture sensitivity. If it's a female, you might do a pregnancy test in women in childbearing. Make sure that it is nothing to do with any ectopic pregnancy or something to do with the gynecological system. So therefore, make sure that if it's a childbearing female with childbearing age, you must do a pregnancy test to rule out any gynecological pathology. So imaging, now imaging is actually not necessary in appendicitis, but sometimes it's a bit difficult to diagnose. So you will arrange ultrasound scan. Often difficult to visualize appendix. So most of the time when you do ultrasound scanning suspected appendicitis, you will not find appendix. If the radiologist is very clever, they might see the inflamed edematous appendix, but most of the time the ultrasound will come as normal. Why we do ultrasound in suspected appendicitis is not to diagnose appendicitis, but to rule out any other differential diagnosis. For example, if it's a twisted ovarian cyst, that can be picked up. If it is a uterine colic, ultrasound will pick up. If it is mesenteric adenitis, ultrasound will say there are inflamed lymph nodes around the RI. So why we do ultrasound is not to diagnose appendicitis, but to rule out the other differential diagnosis. That is why we do ultrasound. And also we do ultrasound if you are suspecting of a mass or an abscess, which can be easily picked up with the ultrasound scan, right? So it is useful in experienced hands, can detect other pathology. As I told you, ovarian cysts and twisted ovarian cysts, ectopic pregnancies. And in some centers, not in this country, CT can be done, 95% sensitivity and 94% sensitivity and 95% specificity. Especially useful if other pathology is considered, for example, cecal diverticulitis, things like that. Right, then what is the management? So you have made, you have seen the patient, taken history, examined, and with CRP, you have done some investigations, full blood count with slightly elevated CRP more than 6, and you have done ultrasound scan, and it says appendix cannot be visualized, but you know, and with your examination findings, you think this is clinically and supported by few biochemical investigations, this is appendicitis. So how are you going to manage this patient? Right. Tell me, how did you manage this patient in your ward where you have seen that patient? What's the management? Management of acute appendicitis. I'm not talking about appendix mass or appendix abscess. I'm talking about straightforward, unruptured, acute appendicitis. The management is surgical, right? Management is operation. So I still will see candidates coming and telling in the Viva, management of acute appendicitis is antibiotic. Don't tell that you are going to fail, right? Because when you make the diagnosis, it is very important to quickly take that appendix out. Otherwise, this can rupture, this can perforate and cause local peritonitis, abscess formation. So when you make the diagnosis of acute appendicitis, the treatment is surgical. So you give some, you start general measures, IV fluids, you give one shot of antibiotics. Also, we give that pre-operatively and post-operatively. If significant signs of sepsis is there, if symptoms or signs are equivocal, observation with frequent re-examination. This is very important. This is what I said, especially if you're a child. If you're not sure, always come back in about 3-4 hours and re-examine, right? Frequent observation, and then you can easily catch the diagnosis. So the management is surgery, appendicectomy. You can do either open or laparoscopic approach. It's very rewarding operation to do this laparoscopically, because if you do this laparoscopically, the patients will go home very early. They can go back to work, say within 2-3 days. Very, very interesting operation, quick operation, very rewarding operation. Patient will really appreciate this rather than having a big cut in the abdomen. So what sort of procedure was done in your patient? Laparoscopic appendicectomy or open? People, can you hear me? Hello? What sort of operation was done? Appendicectomy, open or laparoscopic?
Laparoscopic.
Brilliant, well done. Okay, how many days did the patient stay in the ward? How many days did the patient stay in the ward? Can't remember. Hello?
3 days.
Talk loud.
3 days.
All right, within 3 days, patient went home. Very good. Okay, well done. So post-operatively, you will give antibiotics for about 3 doses. It is straightforward. If it is ruptured and a little bit of local peritonitis, you will continue antibiotics for about at least 3 days. Then if it is appendix abscess, appendiceal abscess, you again have to drain it, open or percutaneous method or laparoscopic method. The ideal method should be drainage is performed either percutaneously, ultrasound guided drainage. If it is an abscess, pre-operatively you diagnose that there is an abscess formation. Best thing would be to get the radiologist to do ultrasound guided percutaneous aspiration and placing of a drain there. But sometimes this is not enough. The bowel is there and it's very difficult to go there ultrasonically, so you may have to do a laparoscopic drainage or an open drainage. So if it is appendix abscess. What about appendix mass? So the history will be when you examine the abdomen, you will feel a mass in the right iliac fossa. So this mass, you are not going to operate. Non-operative with antibiotics, parenteral fluids, frequent assessment of the abdomen to make sure this the size is increasing. With operation, if clinical deterioration, yes. If you are diagnosed a mass, when you are managing conservatively antibiotic, analgesics, IV fluids orally, if they deteriorate, yes, then you offer surgery. If not, the plan is once the patient gets better, they will go home on antibiotic and you will review them in the clinic. And the plan is to do a interval laparoscopic appendicectomy after about 8 to 12 weeks. So about 8 to 12 weeks, sometimes 6 to 8 weeks. So you offer laparoscopic surgery when the mass is not there. When they come for interval laparoscopic appendicectomy, it is important for you to make sure by doing a scan as a house officer that there is no mass. because if still the mass is there, the laparoscopic operation will be difficult. Make sure pre-operatively do ultrasound scan and make sure there's no mass there. That's called Oshna-Sharan regime or Oshna-Sharan approach, right? That is how you manage appendicitis, right? Okay. So what are the complications? Inflammatory mass, appendix abscess, perforation, and peritonitis, which I have told you. Rarely you can get portal pyemia. Post-op wound infection is very common. Very important to tell the patient because we are operating on a contaminated site. Tell them that there is a high chance of wound infection. Sometimes when the wound infects, patients find that the surgeon is at fault. It is not the patient or anyone's fault. It is the nature of the disease. So as a house officer, when you take consent from this patient, you must tell all the possible complications and get them to sign the paper. Tell them that there's high chance of wound infection. Don't get surprised if you develop wound infection, right? What is the prognosis? Appendicectomy is curative. If untreated, it can be life-threatening. Diagnosis can be difficult in the very young, in the very elderly. I told you in very elderly, this may be associated with cecal carcinoma. And in pregnancy, diagnosis will be a bit difficult. Morbidity and mortality in these subgroups are higher, right? So that's about appendicitis, right? So we are right on target today, right? So what are the questions that you have? Ask the questions. We can move on to the next topic. Okay, will give 5 minutes for you to throw some questions. Can't hear anything. Hello, people. Hi. Can you ask some questions? Nobody's there. Pause. Hello, can you hear me? Can you hear me?
Yes.
Right. Okay. What are the questions that you have on thanks on appendicitis, appendicectomy? You ask me questions. Without knowing about this, you can't do a clinical appointment. You must know about appendicitis, appendicectomy, everything very thoroughly. What are the questions you have?
So why amylase increase in appendicitis?
Here. Ask me again.
So why amylase increase in appendicitis?
That is usually in general, in acute general acute problems in the abdomen, the amylase can go up. That's a known thing, right? So you will not do amylase in every patient, but if you think that there is if you consider diagnosis difficulty, you will do amylase. But usually amylase can go up, not to the extent of acute pancreatitis, but it can go up in almost all the acute general surgical problems, right? So we are moving forwards. We are talking about diverticular disease. So what is diverticular disease? Can anyone think and tell me? Can anyone think and tell me? Because this is a very anatomical. This is a very anatomical thing. Because these are diseases that happens due to anatomical problems in the bowel. What do you think about diverticular disease? What are diverticula?
Small bulges from the...
Yes. So small bulges or outpouchings that happens from the bowel wall, right? So if you have not heard about these things, you must think and tell us some reasonable, give us a reasonable answer. Everything in life cannot be learned and taught. So sometimes you have to think and do certain things, right? Everything cannot be taught and everything cannot be rehearsed. I'm sure you understand what I mean. So if you heard the word diverticular disease, if you have not heard about it before, that is why you have the brain. You have to think about what it is and tell us, give us a reasonable answer, right? So diverticula, what are diverticula? They are, somebody said, outpouchings that happens from the weaknesses in the large bowel lumen. Right. Let's see what it is. So diverticular disease, or this presence of diverticula, there are so many definitions associated with this condition. Just having diverticuli, it's called diverticulosis or diverticular disease. So what is diverticulosis? The presence of diverticuli, outpouchings. Somebody said outpouchings of the colonic mucosa and submucosa through the muscular wall of the large bowel. That is diverticulosis. Just presence of that. Patients not having any symptom, not trouble. Patient doesn't even know that they are having that. If you do a colonoscopy, you will see these things, or barium enema, you will see that these outpouchings are there. But patient doesn't know anything, no symptoms. So that is diverticulosis. So what is diverticular disease? Diverticular disease is, here there's a there's I missing here. Diverticular disease. Diverticulosis associated with complications. It's called diverticular disease. Say, for example, if you have hemorrhage, you can have hemorrhage, you can have infection, that is diverticulitis. And there are so many other complications that can happen with diverticulosis, and this is called diverticular disease. You can have fistula, they can have strictures, you can have mass formation. So many complications can happen. That is why this is an interesting disease which you will have to know. So what is diverticulitis? That is very important for us because patients can present with diverticulitis. This condition is not all that common in the Asian population, very common in the West, but now with that our industrialization and people don't eat a lot of fiber content food, therefore you see sometimes these patients presenting, but it is usually very common in the West. But because of traditionally the Asian people take a lot of fiber in their diet, therefore the incidence of diverticular disease is not all that common as compared to the West in our countries. So there is a classification of acute diverticulitis. If you are interested, you can pay some attention. There's a mass, 1A, 1B, localized abscess, perforation with purulent peritonitis, and fecal peritonitis. There's a called Hinch's classification of acute diverticulitis. So then, what is the etiology of diverticulitis? Usually, it's a low fiber diet leads to loss of stool bulk. Consequently, high colonic intramural or intraluminal pressures must be generated to propel the stool, leading to herniation of mucosa and submucosa through the muscularis. Right. You have not put the equivalence there. Right. Move on to the epidemiology. So as I told you earlier, this is very common in the Western population. 60% of people living in industrialized countries will develop colonic diverticuli. So it's a big proportion, 60% will develop diverticuli. So it's very rare below 40 years of age. And when it happens in Asians, you get right-sided diverticula are more common in Asia. So what are the large parts of the large bowel that diverticular disease can occur? Tell me. What are the parts of the large bowel? It can happen in the cecal. Where else can this happen? More common in where? Anybody?
Sigmoid colon.
Sigmoid colon. Very good. So sigmoid colon, that is most common place, and then it can happen in the cecum. And if it happens in Asians, although rare, it can happen on the right side, which is the cecum and ascending colon. Right. Now, let's move on to the history. So often asymptomatic. I told you a lot of people does not know that they are having diverticulosis or having diverticula in the bowel. No, but they don't know. So they often they don't notice. They are often 80 to 90% of the time they are asymptomatic. So if they are having diverticulosis, what are the symptoms they can have? They can have altered bowel habits. Very important. When a patient comes and tell you, I have altered bowel habits. What is the meaning of altered bowel habits? They will have constipation alternating with diarrhea, or diarrhea alternating with constipation. So there's alteration of their normal bowel habit. That's a feature of large bowel malignancy. We will be discussing those things in the next couple of lectures. But if they have altered bowel habits, you will consider diverticulosis as a differential diagnosis. Then they will have PR bleeding. Now again, PR bleeding, there can be many causes: hemorrhoids, large bowel malignancy, fissure, so many other causes are there. But when you have diverticulosis, they can present with PR bleeding. Then they will have left-sided low abdominal pain in the left iliac fossa if they have diverticulosis. Then what about diverticulitis? Diverticulitis is where these outpouchings or these diverticula are inflamed. Their lumen is obstructed and they are inflamed. And there's infection setting in because they are in the large bowel. There's infection setting in, there's inflammation and infection, and there is a condition is called diverticulitis. So what are the symptoms there? So they are presenting with LIF pain. And this PR bleeding is copious amounts. So you can differentiate the other causes of PR bleeding, because in diverticulitis, they present with massive amounts of bleeding. They come and say it's like an opening of a tap, right? Massive, copious amount, cups of bleeding. Whereas in hemorrhoids, it is just spurting and it stops. In fissure, it is just a streaking of stools with blood. But in diverticulitis, they get huge amount of bleeding. And there's significant left iliac fossa pain. And when you examine, there's severe tenderness in the left iliac fossa because the sigmoid colon is inflamed with this diverticula. And they will have fever. That is diverticulitis. That is very important to remember this condition, because this is how they will present to your emergency ward when you are the house officer. They will come with diverticulitis, copious amounts of PR bleeding, fever and LIF pain, right? So if they have complications, what can happen? So I told you the complications are they can form a diverticular mass. So what will you feel on examination? You will feel a palpable LIF mass, and because of the mass, they can present with large bowel obstruction. So if a patient presents with large bowel obstruction, you will have to consider when you examine the abdomen, you feel a mass in the LIF. What will be your differential diagnosis? Number one may be malignancy. Number two may be a diverticular mass. So if they have a diverticular stricture, what will happen? There's obstruction. Stricture means there's obstruction to the flow of the fecal stream, and they will present with large bowel obstruction. So there's fistula, let's say diverticular disease or diverticulitis, and its mass has fistulated into the surrounding organs. What are the surrounding organs to the sigmoid colon? What are the surrounding organs? Hello? What are the surrounding organs to sigmoid colon? Speak up. Speak up, people.
Bladder.
All right, very good. So this can fistulate into the bladder. What can happen? They can have pneumaturia, they can have fecal uria, they can have recurrent UTIs. Where else can it fistulate, especially in a female? What is the organ between bladder and the sigmoid colon in a female?
Uterus.
Right. So very good. So that they can fistulate into the uterus, and they can have this feces and air coming from the vagina. So fistulation. So diverticulic perforation, what will happen if the diverticula perforate? Can they perforate in diverticulitis? Yes. There's inflammation, infection, they can always perforate. What will happen? There's LIF pain, there's collection, local collection of pus. When you see these patients, you examine them, there will be, oh, what's happening there? There's some quarrel, somebody is fighting. Right. So there is localized peritonitis, and you get ultrasound scan, you will see, it will say there is localized collection of pus, right? So that is diverticular perforation. What will you do if there is a localized collection? What can you do? just like the previous lecture on appendicitis. What can you do if there's localized perforation of a diverticulic perforation? What can you do?
Drainage.
Yeah, you can. Well, after the initial management, antibiotics, all that. I'm just asking about percutaneous drainage, ultrasound guided percutaneous drainage you can arrange. Right. So that is about the history. This is how they will present with various problems depending on the whether it is a symptomatic condition, whether it's a straightforward diverticulosis, diverticulitis, or whether there is any complication of mass, stricture, fistulation, and perforation. So that's how they will present to you. Right. Let's move forward. Okay. So when you are examining these patients as a house officer, this is how this is what you are going to see. Diverticulitis, there will be tenderness in the LIF, right? Clear? When you examine, do the general examination, there will be febrile. When you do the abdominal examination, inspection, palpation, percussion, auscultation, and all that. When you examine the abdomen, you will elicit tenderness in the LIF, and there are signs of local or generalized peritonitis. Depending on if it is perforated locally, you get local peritonitis. If it is generally, you have generalized peritonitis if the perforation has occurred. Pathology and pathogenesis, I have left it for you to go through because you have done this. I am not going to repeat it. That is, you have to just memorize or go back to your pathology notes. Or if you don't remember, better go and meet one of the lecturers in pathology and ask about the pathology and pathogenesis of diverticular disease. Diverticuli are most common in the sigmoid and descending colon, but can be right-sided. Diverticuli consist of herniated mucosa and submucosa through the muscularis. Although I have told you to go and ask the pathology people, I'm going to explain this. Particularly at sites of nutrient artery penetration in the bowel. Divertical obstruction by inspissated feces can lead to bacterial overgrowth, toxin production, and mucosal injury, and diverticulitis, perforation, pericolic phlegmon. This is pericolic, percolic, or pericolic phlegmon. Phlegmon is mass, abscess, ulceration, and fistulation or stricture formation. So this is the pathology which you will have to remember. And when you come to the viva, will be asking you the pathology or pathogenesis of diverticular disease and relate that to its complications. So better read these things and come when you come to the exam. What are the investigations that you are going to do? So you will do a full blood count. If it is diverticulitis, there will be high white cell count and high CRP in diverticulitis, right? Check clotting profile, do a clotting profile, and cross-match if there's a lot of bleeding. In diverticulitis, I told you there's copious amount of bleeding. Very important to check the patient's white cell in the full blood count. You check the hemoglobin, and if you think the patient needs transfusion, you must cross-match blood and keep the blood ready, right? Then, after these basic investigations, you will arrange an ultrasound scan for these patients. So when you do ultrasound scan, usually most of the time ultrasound scan is diagnostic. It will detect if there are local abscess formation. It will detect if there are local perforation and fluid collection, pus collection. It will detect free fluid. And it will tell you the sigmoid or the descending colon is inflamed, edematous, and all that can be diagnosed with ultrasound scan. And if there's a mass formation, ultrasound will tell. So a lot of information can be gathered from by doing ultrasound scan. So if you get the patient, you take history, examine, you come to a diagnosis, and you start your drip. Keep the patient ill by mouth for initial few hours. Then you give antibiotics, broad spectrum IV antibiotic. Most of the time you give cefuroxime and metronidazole. Pain management, very important to make sure that they are not their pain is relieved. So start drip and maybe catheter. If the patient is clinically very unwell, you put a catheter, and then you arrange once the basic investigations are done, and once the basic management is done, the patient is pain-free, you will arrange the ultrasound scan, and you will accompany this patient to the ultrasound department. And when the patient is undergoing ultrasound scan, you will sit with the radiologist and ask them to show you what are the what they see, and they will be very happy to teach you. That is how you learn as a learner. You take this patient as an intern, you take to the radiology department and sit with the radiologist and ask them what they will see there. So they will start teaching you. Sometimes a barium enema, not in acute stage, but when everything settles, patient goes and come to the clinic and you will do a barium enema. It will demonstrate the presence of diverticuli, a very characteristic feature. You can see the diverticuli in barium enema with the sawtooth appearance of lumen, sawtooth, reflecting the pseudo hypertrophy of the circular muscle. So this barium study is not, those type of barium studies should not be performed in the acute setting. There's high risk of perforation. So flexible sigmoidoscopy again, and colonoscopy when the patient goes home after the treatment of the acute episode, and we'll get the patient to the clinic, and from the clinic your consultant will arrange a sigmoidoscopy or a colonoscopy to see the interior of the bowel lumen. Diverticuli can be seen and other pathology. Sometimes these patients can have other pathology, maybe angiodysplasia, maybe a tumor, maybe a polyp. So by doing a flexi or a colonoscopy, you will be able to confirm the presence of diverticular as well as exclude any other pathology. You can arrange a CT scan. Sometimes when there is diagnosis is in doubt, and in the acute state, if it is complicated, ultrasound scan cannot be diagnosed. Not sure, not confirming, ultrasound is not confirming your diagnosis, you can arrange a CT scan depending on the facilities you are available. It's always worthwhile getting a CT scan because you can get a 100% accurate diagnosis. Right. So what about the management? So if you have a patient with asymptomatic diverticular disease, diverticulosis and asymptomatic, and you have diagnosed that by doing a maybe other routine colonoscopy, flexible sigmoidoscopy, you have seen the diverticular, but patient is asymptomatic, or maybe having very mild symptoms. For example, altered bowel habits, mild left-side abdominal pain, so that sort of thing. They're not having any acute problem or complications. In asymptomatic or mild disease, you will increase the fiber content of the diet, high fiber diet. Probiotics and anti-inflammatories are under investigations for preventing recurrent flares of diverticulitis. So you can explain to them that they have diverticulosis and ask them to take high fiber diet and regularize the bowel motion, that sort of thing. Very conservative. So if they have a GI bleed, PR bleeding is often managed conservatively. If they come with copious amounts of bleeding per rectal, manage conservatively, I told you a minute ago, with IV rehydration, blood transfusion if necessary, sometimes angiography and embolization. You can, if you consider any other problem, maybe angiodysplasia or any other thing, if the diagnosis is in doubt, you might do all these other angiography, embolization, or options available. So how do you treat diverticulitis? Again, I had told you a few minutes ago, you treat with an IV antibiotics, cefuroxime, metronidazole, IV fluid rehydration, and you rest the bowel for a couple of days. You ask the patient not to take anything solids orally, just stick to only fluids for the first 2-3 days until the bowel heals. And localized collections of abscesses may be treated by radiologically placed drains, so ultrasound guided percutaneous drainage of these collections and abscesses can be done. You can get the help of your radiologist. And again, if you are the intern, these things happen in my ward. Okay, if you are the intern, you have to take this patient to the ward, the radiology department, and see what's happening there. Right, percutaneous drainage of collections, and you have to go and accompany and see what's happening there, and you have to come back and tell us what happened. That's a good learner. You just don't send the patient and you sit in the ward and wait until the patient comes. You go with the patient and you see what's happening. You give them a hand, assist them, you wear gloves, right? You assist the radiologist to do this procedure. Then they will tell you. They will tell you what they are doing. They will teach you. So you can do percutaneous drainage. Surgery may be necessary with recurrent attacks. Now, so for example, somebody recovers and goes home, but sometimes they come with recurrent attacks of diverticulitis. Then it's a big problem, because with each attack of acute diverticulitis, there are a lot of fibrosis. The small bowel and all the other organs, bowel come and get adhered to this area, and the operation, if you are planning any operation in the future, it will be very difficult. So therefore, sometimes if these patients come with recurrent attacks, you might think about doing a elective sigmoid colectomy. So surgery has a place in these patients. This is very controversial at the moment, whether you do it after first episode or whether you do it after many episodes. It's a very difficult area. People have not come with straightforward protocol. It all depends on your personal experience, surgeon's personal experience. Sometimes people do it after first episode to prevent, because if you wait until recurrent attacks happen, there will be a lot of adhesion formation and the future operations will be very difficult. So sometimes some centers, some people, some surgeons will operate after the first episode and do a sigmoid colectomy laparoscopically or open. So therefore, prevent any further attacks of diverticulitis and its complications. So surgery may be necessary with recurrent attacks, as I told you, or when complications develop. Definitely, if you have a diverticulitic mass or a stricture, you have to do surgery, because otherwise the patient will come with intestinal obstruction, right? So when the complications happen, you will have to do anyway offer surgery. Surgical treatment can be open. Yes, as I told you, you can do open surgery or you can do laparoscopic surgery. So very controversial area. You are not to worry about, don't worry too much about this area, because nobody has got proper, nobody has come out with proper protocols. People do surgery here. It's all a personal preference and personal matter. Sometimes after first episode, sometimes after many episodes. But with recurrent attacks of diverticulitis, remember, somebody asks you, tell that there's a lot of adhesion formation and operation will be quite difficult. That is why a lot of people operate after the first episode. Right. That's about the management. Okay, I think we have come to the end. Right. So here you are. If you are doing surgery, you can remove that part of sigmoid colon and offer Hartmann procedure. Hartmann procedure is where you resect that part of the colon and the proximal end is brought out as a stoma. Or you can do it as a one-stage resection and anastomosis. There the risk of leak is high. And you do a defunctioning ileostomy. These are all surgical techniques which I will not expect you to know in great detail. So more recently, laparoscopic drainage, peritoneal lavage, and drain placement can be effective. These are not too important for you. What is important for you is to take a good history and examine the patient. And when your consultant comes to ward round, present a good history and present a good examination findings and manage the acute situation of the patient. That is more than enough as house officer if you are working in a surgical ward. Right. So what are the complications? I already mentioned about the complications. Diverticulitis, pericolic abscess, perforation, fecal peritonitis, chronic obstruction, fistula formation, lower GI hemorrhage. These are the complications of acute diverticulitis. So what is the prognosis? 10 to 20% of patients will have one or more episodes of diabetes. Now this is why people offer surgery after the first episode. 1/4 of patients will have more than one episode. And when they come with another episode, always with each recurring episode, there may be more and more adhesion formation. Operation will be difficult if you don't operate early, right? And when you operate on a difficult pelvis, the more chances of these people going for a stoma, right? So there is more adhesions. Bowel has got stuck into this mass. So more chance of patient having a colostomy. So therefore, you operate early, you can avoid a stoma, and maybe you can anastomose primarily, not giving any stoma to this patient. So those are the advantages. So if you are aiming for a distinction, a gold medal in surgery, these are the things that you have tell us in the exam. So early surgery, less risk of stoma. Late surgery, after a couple of episodes, more adhesions, difficult operations, so patient might end up having a stoma. Nobody wants to have a stoma, especially for a non-malignant condition. So therefore, early operation has a place here. Right, okay. Let's see. That's the end of it. Right, okay. Fire me questions. Right, okay, people. We are right on target today. Excellent. Fire me questions. Throw your questions out. People, wake up from sleep.
At the same time, can the patient have diverticuli in esophagus?
Diverticulitis of the
Esophagus, I mean.
Not that common. Diverticular of the esophagus. We are basically talking about diverticulars of the cecum, descending and sigmoid. Any other questions? Right. Tell me that you are there. 131. Tell me, I am there. One by one. Huh?
I'm there.
I'm there.
Very good.
There.
I'm there.
Shout, shout, shout.
I'm there.
I'm there, sir.
Hey, I can hear only one male voice. Come on. Are you there?
There.
Some more. Come on.
I am there.
Okay. So what
I
are
am there.
do you have any problem with your laptop?
I am there, sir.
So are you sharing with people? You have problems with access to the LMS? Or you are okay?
No, sir.
Why are these other people not coming? Today 145. 50 people have not come. Why is that? 50 people have not participated. What's the problem? Are they having corona? Hello?
Only 169 in our batch.
How many in the batch?
169.
But on the first day, I got 195. I think other batches have also joined. But here, now the participation is not good. Okay. Right. Okay, then that's about it. Very good. Hurry, hurry.